Welcome, everybody. On behalf of Andrew Morris, who is unable to be with us, I'm Martin Murphy, and I'm very pleased to extend this welcome on Andrew's behalf. He hopefully will be able to join us later. He is doing what might be described as the next right thing. A mentor and dear lifelong friend has been promoted into eternity, and Andrew is at his memorial service and begs your indulgence. It is an honor for me as a co-chair with Agnes Binawahu of the ICODA's Scientific and Strategic Advisory Council to welcome all of you and to thank you for your participation. This is going to be a very important session. Actually, it's a showcase of what has taken place, what you have enabled to take place. And it is also an opportunity for us to express to our benefactors, to our colleagues, and very importantly, to our patients and caregivers, our gratitude. It's very also important that we stay to time. And I promise to try and help us in doing so, as we have 12 driver projects. It is the real gemstone of this meeting, and that is what we're going to devote our major time to. Questions and answers, please put them in the Q&A button at the bottom. Of course, you have the opportunity also to chat one with another, with everybody, or individually, as you know, in that chat function. Real discussion will be conducted by Ann and Neil at the end of the driver project presentations. But that does not mean you should not ask your questions pro tempore as presentations are being made, but do so please in the Q&A button. And there will be ample opportunity for discussion at the end, towards the end of the webinar. We ask all of you to recognize that this is being taped. Why? Because it really is historic. And what I'd like to do is ask my co-chair, Agnes Binawahu, to give some reflections on not only what brought her to this important project of ICODA, but also what has kept all of us here. Agnes, may I turn it to you, please?
Thank you, Marty. I think that, yeah, it's an important moment. And since the beginning, we have worked all together to reach this as a step, as one of the steps where we are going to fulfill and implement our full vision. It's important to have, what we wanted is that there is a lot of research ongoing in the world, a lot of great results, but no exchange among the researchers and no sharing about the results. So our objective is to accelerate the impact and the outcome of research by pooling results together, researchers together, etc. So you will see today where we stand. We have made progress. We have taken the current pandemic as the pillar of our movement, and it has bear fruits. And now we go further. How can we do that in oncology and in other spheres, so that we share among researchers methodologies, results, outcomes, so that we accelerate the wellness of the population worldwide? That's what I can say.
Brilliant. Agnes, as always, thank you. You set now, as you have always, set the perfect tone. My only comments as complementary to Agnes's is that these 12 driver projects I see as facets being cut by these 12 teams on a gemstone, a diamond. And as we know, diamonds are created under great pressure. And so ICODA, as itself a gemstone, has been created under the tremendous and awful pressure of COVID-19. And now with these driver projects, facets are being carefully cut on this diamond that will then enable the luminosity, the information that is trapped within ICODA, within this awful pandemic, to be released through each of these facets to illuminate our understanding. And with maturity of data, perhaps even derive new knowledge that will be a savings for all of humanity as time progresses. So it is here that we're now going to be treated in a showcase to the facets that have been cut by 12 outstanding teams who are driving these projects. And now over to Anne and to Neil to carry us forward. Thank you very much.
Thank you very much indeed, Marty and Agnes, for those lovely introductory comments. As Marty says, Neil and I now just want to take a few minutes to give a little bit of a concise overview of the ICODA initiative, where it started, how it's the approach that it's taken, and the achievements and progress that has been made. And I'd like to begin by focusing on the vision and mission that was initially agreed for the initiative right back when it was established in July 2020. And as you can see, the vision was very much about using data science approaches to reduce the harm of the ongoing pandemic, but much more so to also make a longer term contribution to addressing the challenges of future pandemics and global health challenges. And in that, ensuring that it reduces the harm of COVID-19 for everyone, everywhere. The mission of ICODA was very much setting out about how this was going to be achieved, not only through providing rapid research findings and insights to manage the pandemic, but also providing an approach and a legacy and a strong long-term alliance that would have longevity and have impact that was sustained. So the following slide sets out the 4 key elements or pillars of the ICODA initiative, which have provided us with such a strong framework. And I'd like to start just by saying how important the collaborative approach has been. And we've sought to build a global alliance working in partnership very broadly with researchers, academia, industry, and with leaders of health systems to ensure a coordinated, focused approach. And that's brought together so many important different perspectives. Also, the truly global international approach has been essential, and there's been a particular focus on working with leadership from researchers in low and middle income countries. The second pillar has been around the trustworthy data ecosystem, and there have been a number of elements of this. Crucial has been the community, public, patient engagement from the outset, each of the research studies and the initiative as a whole. And I think you're going to be hearing some amazing narrative about the research studies and how this approach has been embedded. Robust and transparent governance has also been very important, particularly looking at the approach that's been taken through our governance policies and processes, taking an ethical approach. And the 5 SAFEs approach has been particularly important in this element. For enabling scale and longevity, it's been very much about taking the FAIR approach, making data findable, accessible, interoperable, and reusable. And the ICODA, and more recently the HDR Innovation Gateway, has played a very key role in that, as our COVID-19 digital workbench, providing a secure, trusted research environment for our researchers, and particularly allowing federated access when data couldn't be transferred. Again, that's been a very important part of the initiative. But last but not least has been this crucial pillar on using the driver project approach, which has been central, and it's helped shape the approaches, the policies, the practices, and the tools that have been developed to ensure that these best meet researchers' requirements and also accelerate research findings for all. Supporting each of these pillars have been the principles, and the principles are set out here. And we've asked all of our researchers and partners to subscribe to these. I think many of them will be very familiar to you all as key partners in the initiative. And I think particularly, again, there have been many key elements on this, particularly in fostering equity, being inclusive and collaborative, and also the protection of privacy through commitment to the 5 SAFEs framework. That's people, project, safe settings, safe data, and safe outputs. On the next slide, just like to acknowledge the incredible contribution of our governance and advisory groups. There have been 4 of these, and their championing, their guidance, their advice, and their commitment has been exceptional. I particularly like to mention our co-chairs, who we're very fortunate to be joined by today, of the Scientific and Strategic Advisory Council, our Ethics Advisory Council, and our executive leadership team, who have been steadfast throughout the initiative, and our statistical expert group, who played a particularly important role in supporting each and every one of the driver projects that you'll be hearing about today. And at this point, I'll hand over to Neil.
Thanks, Anne. Fantastic. Hopefully that gives everyone a bit of background as to how we set the initiative up. My privilege to talk about some of the progress and outputs of the initiative, thanks to all of those who are with us on the call today. It really is the hard work of our research teams and our partners that's got us here. As you can see, we've had a very much global presence with a selection of driver projects, really with research leads from right around the planet. It's been fantastic. We've had 135 researchers engaged, 19 countries, 60 countries providing all sorts of different data types, and community and stakeholders engaged right across the globe. So really fantastic. All of our projects completed at the beginning of October. And the initiative itself is really only 2 and a bit years old. So we started just after the pandemic started in July 2020. So it's been a short, sharp project, but some of the outputs have been fantastic. The initiative's enabled 37 publications to date by all of our fantastic researchers, who you're going to hear from soon. We've created generic policies and processes, so hopefully nobody needs to start from scratch again, as we did with this initiative. There are many, many dashboards that have been informing public and policymakers across the globe. All of our data sets are available for reuse, and we now have a very active global health data science community, of which the research teams you're going to hear from today are very much an active part. So fantastic progress, fantastic outputs. From a pillar perspective, we've really had some great new partnerships that have set the ball rolling for the initiative from the get-go, right across the globe. That's both technical and more broad alliance partners. We've had great engagement to make sure that we really did this in a trustworthy fashion. The ethics and governance framework, which was set out by the Ethics and Advisory Council very early on, really informed the entirety of ICODA's efforts and generation of everything in the open, which has been a really good lens to look and help all of the projects with. And we made a technical decision as well that we weren't going to build things as part of the initiative. We were going to reuse, we were going to assemble, we were going to partner, and we would very much do that again, because it really gave a springboard for the initiative to get started with. And I think a novel thing about ICODA is we chose to, as Anne said, use a trusted research environment for all of our research teams to provide a safe setting within which they could perform their research. So this was cloud hosted, available across the globe, and provided by one of our key partners, Iridia Informatics. So that proved really useful. And driver projects as well. I think the driver project construct really saved the ICODA initiative from over-engineering anything. I think there was absolutely nothing put in place from either a technical or a governance perspective if it wasn't absolutely needed by a driver project for their immediate delivery. So we really made sure everything we did was supporting the research efforts. And that lens was fantastic and one I would recommend to any initiative going forward. If we look at the legacy, we have a variety. We have the traditional research measure, 37 publications enabled from some of the fantastic teams you'll hear from today, many in high profile, high impact journals. We've got lots of different outputs as well. So transformational code, dashboards, governance policies and processes, and generic governance processes as well. We've really gone to town on trying to make sure that we de-ICODA-ize a lot of those processes. We've made them available on both the ICODA website and our Global Health Data Science Digital Hub, which you'll hear about later. And we'll be able to track the future resource use of all of these things through digital object identifiers. We've tried to make sure that we use DOIs for all of the outputs of the initiatives. We will continue to make the metadata and data sets available. They will be moving across from the ICODA Gateway to the HDR Innovation Gateway early in the new year. And all of the technical partners who've been with us right through the ICODA initiative are standing by for working across the globe on future projects. So be that trusted research environments, data curation support, metadata cataloging, we are able to pull all of those partnerships together. And we do have an active global health data science community of practice that is open and available for all to join. So with that was a quick whistle-stop tour, very high level from myself and Anne. I'd like to pass the baton now to Kim Carter, who is Health IT Project Lead at the Minderoo Foundation, and Minderoo, one of our co-funders for the ICODA initiative. So Kim, over to yourself, any reflections you might like to share.
Thanks very much, Neil. I'm representing Minderoo on behalf of Dr. Steve Bennell today, who's head of our COVID-19 response and unfortunately couldn't be with us. The pandemic really highlighted the crucial role for collaboration and data sharing in addressing global health challenges. And the rapid and unpredictable spread of the virus, I think, really emphasized the need for collaboration amongst different sectors, bringing together public health, academia, industry, to really develop data-driven, effective interventions to coordinate a response effort. Data sharing is a really key pillar of Minderoo Foundation's approach to health research. And so we jumped at the opportunity to join with Gates Foundation, with the Wellcome Trust and other key partners in early 2020 to found ICODA and to quickly respond to the rapidly emerging pandemic. And just as Neil and Anne have just done, I think if we reflect on some of the impact and successes of ICODA for a moment, the creation of a rapidly establishing a globally significant data sharing platform and analytics workbench as an accelerator for COVID-19 research in 2 short years is pretty amazing. I think, you know, in enabling the discovery, access, analysis of these multidimensional data sets in accordance with, you know, local governance requirements, for the individual data collections from each country, supporting rapid clinical decision making, and really focused collaborative research is an amazing achievement. Bringing together pharma and academia together across the globe is not something that routinely happens in research, and certainly doesn't happen enough. You know, these high profile and impactful scientific achievements and that have outputs that have been highlighted already, as Neil just said, the 37 publications and many more to come along, is a massive achievement in such a short amount of time, and really highlights how this type of approach can really move from inception to producing impactful outputs in a short period. But also more broadly, I think, you know, we've highlighted the importance of resilience and readiness to protect against the long-term effects of COVID-19, and it's really tackling the grand challenge of how we facilitate international collaboration platforms and infrastructure for early detection and rapid response of future biologic threats. In particular, beyond the driver projects, we've been really keen to see that wealth of data and learnings the ICODA teams accumulated, particularly on the barriers and pain points to rapid scientific collaboration and open data sharing. Those data privacy, IP concerns, governance, as Neil's just touched on there, those learnings on how these can be overcome. So it's really fantastic to see these program learnings being shared to the science, and you know, alongside the scientific outcomes, there's an equally important piece of knowledge to share to guide future efforts. ICODA has really generated a positive legacy from this crisis and cemented itself, you know, with the next generation of sophisticated collaborative research efforts to accelerate medical science. And yet there's still further work to do, you know, understanding the long-term impacts for the disruption to maternal health services, to early childhood learning, to cancer diagnostic and treatment services, which is one that's very close to our hearts. And, you know, and a plethora of other critical areas in the long term is really only going to be realized through continued excellence in open data sharing post-pandemic. So we join with you all in celebrating the many successes and achievements of the Alliance, and really would like to pass on some final thank yous to the other key funding partners for your generous support and the vision to support this ambitious and exciting initiative, to the HDR UK team, particularly Andrew, Trudy, Neil, and Anne, who we've spent a lot of time with. You know, thank you for your dedication and perseverance and your truly collaborative efforts to not only bring this Alliance together, but to ensure it thrived. And finally, a thank you to the broader network of researchers, research partners, collaborators, and contributors who've really, you know, for bringing your enthusiasm, expertise, to make this a globally significant and impactful Alliance. So thank you all.
Wonderful. Thank you, Kim, for those kind words. Right, over to, as Marty said, the exciting piece of the day, the showcase. So what we're going to do is something of a relay race between our research teams here. So just to set the relay rules, everybody has 5 minutes to present. Folks have got one or maybe just a small handful of charts. And I will be shepherding us through with the help of Anne in the background as well. So really looking forward to this. This is the highlight of the day, the year, and the overall initiative as well for all of us. So it is my absolute pleasure to invite up first Dr. Gordon Fuller. So Dr. Gordon, Pandemic Respiratory Infection Emergency System Triage, also affectionately known as PRIEST. Take us away.
Hello, good afternoon, and thank you all very much for the opportunity to present the PRIEST study. My name is Gordon Fuller. I'm an emergency medicine consultant and researcher from Sheffield in the UK. This was an international collaboration using data sets of patients accessing emergency care services across low, middle and high income settings in Sudan, South Africa and the UK. Emergency care systems, especially in low and middle income countries, have the potential to be overwhelmed by the demands created by the COVID-19 pandemic, especially if new variants of concern cause future infection waves. Existing research has focused on the prediction of inpatient mortality in patients with confirmed infection to help guide intensive care allocation decisions. However, emergency medicine clinicians need evidence-based, clinically usable risk stratification tools to support rapid decision-making about the need for conveyance to hospital, inpatient admission in patients presenting with suspected infection. Existing emergency triage tools are not specific to COVID-19. There is one or two COVID-specific tools, but they've been developed in high-income settings and might not be appropriate for less resourced countries. So in this project, we aim to improve the initial triage and risk stratification of emergency presentations of COVID-19, focusing on those lower resourced health systems. We use data from approximately 500,000 patients with suspected COVID-19 infection who accessed emergency department care. And we studied 4 cohorts of patients from the UK, 2 cohorts from South Africa and the Sudan. The data covered a range of waves from the COVID-19 pandemic, including cases with the original ancestral Wuhan strain, right the way up to the predominant recent Omicron variant. And using these data, we performed 3 main analyses. Firstly, we looked at how existing non-COVID specific triage tools performed in predicting adverse outcome. Secondly, we trained new prediction models for adverse outcome in ED patients. And then finally, we tested these models across our cohorts of patients. So firstly, we looked at how the existing toolbox of triage instruments performed in those lower and middle income settings and see whether they could detect adverse outcome defined as death or need for critical care. We applied each of these tools to our data across those lower middle income settings and examined their performance compared to current clinical practice. We found that they didn't really improve management compared to what doctors were doing already and could result in a lot of extra admissions. And that really motivated the next step in our project, which was to develop new prediction models. We did that firstly in our South African alpha, beta and delta wave data, looking to predict adverse outcome using machine learning techniques. Our model showed the most important variables for predicting adverse outcome were the requirement for oxygen, the patient's peripheral oxygen saturation level, their age and level of consciousness. We had excellent results on internal validation with a very good discrimination, C statistic of 0.91 and excellent calibration. Performance was somewhat reduced in our temporal and geographical external validations, but we did achieve good discrimination with C statistics of 0.84, 0.62 and 0.72 across those different validation sets, and that was the Omicron wave, Sudanese data and UK data respectively. So our overall goal was to develop a validated emergency care risk stratification tool that was applicable to low income settings that would aid decision making around admission to hospital or conveyance to hospital. Our models appear to have better performance across those low resource settings compared to existing non-COVID triage tools and outperformed existing prediction models which have been developed in higher resource settings. However, we did see that performance did vary across our temporal and geographical external validation cohorts, and that may reflect calibration drift or spectrum effects from deploying our prediction model in different settings. We therefore recommend some further independent external validation, impact studies, and some qualitative work to explore acceptability around using these machine learning algorithms prior to any introduction of the current model into clinical use. It may be that updated model training and recalibration may be required as the COVID-19 pandemic evolves and future variants of concern emerge. We've got 3 publications pending. Hopefully we'll be able to share those with ICODA very shortly. They're in peer review at the moment. Thank you very much for your attention, and we really welcome any questions at all.
Brilliant, thanks Gordon. And with 17 seconds to spare, that was really good. You did have a couple of other charts, but we'll skip through those, but thank you. Baton passed beautifully to Naveen Zarifa, who ran the efficacy and safety of COVID-19 treatments. Naveen, do we have you? That's a no, potentially. So I will come back to Naveen shortly, and we will go to Dr. Xiaofan Lu for characterizing COVID-19 transmission chains for precision mitigation using epidemiological survey data. So Xiaofan.
Okay, thank you, Neil. Hi everybody. This is Liu Xiaofan, and I'm from City University of Hong Kong. I would like to, well, thank ICODA program on behalf of our team for providing us with the opportunity to pursue one of our common interests in studying the transmission characteristics of COVID-19. So we are a team composed of 2 universities from Hong Kong, 2 from mainland China, and also another one from the UK, the Cambridge. We were working on something before this ICODA program, and our focus was mainly on, well, characterizing the reproduction numbers, the serial intervals, and all these kind of very basic and very, well, also very important metrics for not only COVID-19, but also all the other transmission diseases. Well, in this project, our end goal is to, well, really look at how actually this disease transmitted from people to people, and trying to characterize these transmission chains, which you can see on the left bottom figure over there. And these data were actually extracted from epidemiologic survey data from mainland China, from Hong Kong, from and mainly other, well, Asian countries like Indonesia, Philippines, and also some from European countries. Right, so we, like, first of all, we reconstructed or extracted these transmission chains, transmission trees from these data, and did some calculation on the very basic statistics. But later on, as COVID unfolded in 2021, a lot of countries, they stopped providing these detailed epidemiologic survey data to the public. So the thing is that we ran out of data to calculate. And the interesting thing is that we didn't stop our work at that time, but we also focused on, we still focused on how to calculate these reproduction numbers and serial intervals from more, high level and, well, abstract data, for example, just from how many cases are there per day, and plus something that some knowledge that we have already drawn from the previous research on these transmission chains. We were able to, well, develop algorithms to actually infer the reproduction number and all the other metrics from well, more abstract or more statistics level data. So hopefully that's well, our methodologies in studying these actual transmission chains and inferring basic metrics from statistics data could help future work in, well, studying or fighting against large scale transmission disease. Our, well, work around these studying the or modeling or calculating these statistics have been, well, published on Nature Medicine, Clinical Infectious Disease, Journal of Travel Medicine, and iScience, and all the other kind of outlets. Right. So again, we would like to, well, thank the ICODA program for providing us with the resources, necessary resources, and a fantastic platform for our teammates in Europe and in Asia to work together in the past 1.5 years. Well, thank you very much, Neil.
Thank you, Xiaofan. Wonderful. Really exciting stuff. We are going to go back. I think we have Naveen safely online with us now. So I'm just going to go back a couple of charts to catch Naveen. So Naveen, if you can come on camera.
I'm here.
And if I can make the charts go back, let's have a look. So welcome, Naveen. Efficacy and safety of COVID-19 treatments. You had the dubious pleasure of being driver project #1. So take us away.
Thank you. So driver project #1 was really concerned about two things. First was, what kind of level of understanding could we glean from data in aggregate in terms of those drugs, repurposed or new drugs, to treat COVID-19? The other question that we posed ourselves was, how far can we push summary level data? So what can we learn from data that is basically the results of, or subgroup results of, studies that are conducted? My colleagues on this included quantitative experts from 2 consultancy groups, experts from pharma, academia, and even recently retired FDA experts. We had 2 paths that we followed. One was a data dictionary-led approach where the pharma companies were going to provide the data from their RCTs in much greater detail than what would be published. But the work that I want to share with you today is really driven by a publicly available data asset, so something you all have access to. And what this data asset consists of is of the most important data that have been published, so data in the public domain. We provide you all the metadata descriptors of the studies themselves, the populations, the endpoints, even the statistical analysis methods, and then of course the results, be they overall or by subgroup. Very much harmonized and curated over hundreds of studies. I'll speak of one result in detail because we've presented it at ISPOR recently, and 2 other projects that are ongoing have to do with methodologies for the evolution of standard of care in a pandemic setting. How can we account for that as you're doing work on an aggregate data set that spans multiple years? And the other one, led by colleagues at Duke, also to report sometime early next year, has to do with multivariate network analysis. So looking to understand a set of treatments, but not just looking at mortality endpoints, looking at in-hospital disease severity and so on and so forth. Now, the result that we presented at ISPOR is an interesting one. I think I have maybe 2 minutes, so I'll tell you about it in 2 minutes. We looked across 8 different drug classes of repurposed drugs for COVID-19, and we looked to compare real-world studies, observational studies, the results of those versus the results of randomized controlled trials. What we found is that the real-world studies, by and large, they're quite variable in their results compared to the RCTs that are really quite tight. And also they exaggerate the result that is then seen in RCTs. And this is important because the real-world studies read out before. And so even when we look at what are the factors that help to explain this discrepancy that I've described, this overestimate of the repurposed drug effects in real-world studies versus the RCTs, we could only account for about half of them. And the other aspect is only 3 factors would account for about half of that differential. Small study size. So really think carefully if you're going to do small studies. And then secondly, what was the time of observation for mortality? If it was less than 2 weeks, it tended to really be quite off the bulk of the results that are 28 or 4 weeks. And then lastly, whether or not they were able to account for the bias in things like disease state and age, gender, some very obvious kind of confounders. The only other thing I will say about this is we were able to look at longitudinally as results read out, when did we garner the most precision in those treatment estimates? And I'm sure this group will not be surprised, even if there are hundreds of studies for a drug class, the real world studies don't contribute a lot because of that variability. And the most important thing is to have the very large studies, in this case, platform studies for COVID-19, read out as quickly as possible. That's where we get the bulk of the precision in the estimate of the treatment effect. So once again, a large collaboration. We're able to share these data with you. Lots of different research questions can be answered using this data set. Neil, back to you.
Brilliant. Thank you very much, Naveen. Excellent. Right. We are, oh, hang on. What have I done here? Turned on captions or something silly. Sorry, slight technical hitch. Let's go to next up is Dr. Catherine Arsenault, impact of COVID-19 on health service delivery and institutional mortality. Catherine, over to you. Just confirm you can still see my screen.
Yes, we can see it.
Perfect.
Thank you. I'm Catherine Arsenault. I'm currently based at the George Washington University in Washington, D.C. So our project, which we call the Record Driver Project, it stands for Assessing the Resilience of Health Systems During COVID Using Routine Data. So the goal of that project was to identify how the COVID-19 pandemic and the lockdowns or containment policies put in place had impacted health services and institutional mortality at the early stages of the pandemic. Our project included initially 7 countries: Ethiopia, Ghana, Haiti, Laos, Mexico, Nepal, and KwaZulu-Natal in South Africa. We had 3 teams from 3 other countries who ended up joining, which were Thailand, Chile, and South Korea. So a total of 10 countries. And what we wanted to do across these 10 countries is compile a large data set on essential health services and try and compare what was happening with essential health services during the pandemic, which, as we now know, were heavily impacted due to COVID. The type of data that we use was routine health data, HMIS, and other kinds of administrative data, depending on the country. We compiled data from between 24 and 30 months, so from January 2019 to approximately June 2021. And these data were either at the facility level, which is the lowest possible level in these data sets usually, or at the district level. And we compiled data on a total of 31 different essential health services from, maternal and newborn health, child health, chronic disease services, infectious disease services. And what we found is that across nearly all countries, there were some important declines, as the graph shows here at the bottom left, important declines in many health services across nearly all countries, which are likely to have indirect health effects from disruption in essential healthcare. We published a series of manuscripts, some multi-country analyses and some country-specific, like the one showed here from Ethiopia. We presented these findings at the Health Systems Research Conference recently in Bogota, Colombia. We also had some dashboards that were created throughout the project for more real-time kind of assessment of what was happening with health services. Could we go to the next slide? So this is just to give you a sense of the kinds of data that we compiled. It was a pretty large set of different kinds of data. So in Ethiopia, Haiti, Ghana, Laos, Nepal, and in KwaZulu-Natal, South Africa, we extracted data from the DHIS2 platform. So we had some common kind of learnings in these countries on these same types of data. And in the other countries, the data sets were all kinds of administrative data from ministries of health, generally owned by the ministry. Next slide. So in terms of some of the things we learned from this project, some things that worked well, we had a mix of researchers and policymakers in nearly all countries that were involved in both the, accessing the data, the analyses, and also disseminating the findings. So that was definitely a strength of our study. We also made sure that all of our statistical code was available on GitHub for others to try and reproduce these findings, or to use the same kinds of data cleaning procedures, for example, that we employed. Some of the barriers were, the amount of data science skills that are required to analyze these large data sets. And so in terms of future work, post-COVID, we believe that there should be more work done with these routine health data, and that there is definitely a need in health systems research to use routine health data such as HMIS, DHIS2 further. There are still some data quality challenges for sure with these data sets, but without better demand and better use of data, quality is unlikely to improve. Another kind of finding from this research is that many countries continue to analyze these data at the aggregate level, so at the district or community level only. And there's definitely a need for more facility level analysis that could be very informative for health system planning, for example, for understanding patient flows, bypassing of facilities, user preferences, things like that. And we look forward to continuing this work. Thank you.
Wonderful. Thank you, Catherine. And just for folks as well, if you have questions for the PIs as we go along, please do use the Q&A. We are now going to Professor Sir Aziz Sheikh for the International Perinatal Outcomes in the Pandemic. Aziz, are you there?
Yeah, thanks very much indeed, Neil. And hi, everybody. Great to be part of this. So I've got the privilege of presenting on behalf of Driver Project 2, which teamed up with the IPOP team, the International Perinatal Outcomes in the Pandemic team. So this is a team of investigators that were assembled in the light of the pandemic, led by colleagues from across the world, so Megan Azard from Canada, David Bergner from Australia, and Sarah Stock from Scotland, and so presenting on behalf of this group. And so what we did in this work was try to answer the question as to what impact lockdown had on early life outcomes. And the early life outcomes that we're particularly interested in were preterm birth and stillbirths. The context for this work was that there were early reports emerging that lockdown was having an impact, particularly on prematurity, but there were mixed messages emerging from different countries. And so what the team did was assembled an international group of investigators. So in total, I think we had 114, brought together data from 26 countries and overall around 52 million births. So this was a phenomenal undertaking. These data comprised both of population level data, which was our preferred data source, but also facility level data, because in some countries that they were the only data that were available. What the team did was an interrupted time series analysis across these different countries, and then pooling of the data. And we were aided greatly by, in this work by partnering with Iridia and Cell Data Bank. So I wanted to give these guys a shout out really for the fantastic support. The headline findings were that what we found was that lockdown was associated with a relatively modest reduction in prematurity, but at population level, this would translate into quite substantial numbers of premature births being averted. And importantly, it was not associated with any increase in stillbirths. So a really important kind of finding there. There have been a number of publications. This work has attracted a lot of interest from leading journals. The headline paper is shortly due to come out in Nature Human Behavior. But just on behalf of the team, really very grateful to ICODA and the funders for all their support to enable, I think, this timely and important work on an unprecedented scale. Thanks very much indeed.
Wonderful. Thank you, Aziz. Okay, now the relay baton goes to Dr. Joseph Uma and Dr. Lauren Hookham for the incident and risk factors for COVID-19 amongst pregnant and lactating women and their infants in Uganda. So Joseph and Lauren, over to you.
Hi, I hope you can see my face.
I can see you.
Good, thank you. And thank you, Neil, and everyone on the call for this opportunity to present from our work in Uganda. My name is Joseph Ouma, working here at Makerere University, Johns Hopkins University Research Collaboration. And I'm presenting this on behalf of our PI, Professor Kirsty Ladro, and on behalf of our colleagues here in Uganda. So our project, the IROC, DP IROC, was looking at the incidence and risk factors for COVID-19 among pregnant women and their infants in Uganda. The particular goals of this project was really to develop a risk factor model for the indirect and direct effects of the pandemic on MNCH services in Uganda, identify that risk population, and develop a Ministry of Health dashboard for real-time data at one of our largest hospitals here in Uganda. So we used data from a large national referral hospital here in Uganda called the Kawempe National Referral Hospital. The hospital sees over 30,000 women annually, quite a very, very large hospital. And the hospital also uses Uganda, what we call the Uganda Electronic Medical Record System that captures individual level data for women accessing services. So for this particular project, we looked at data for the period January 2020 up to October 2021. And we're really focusing on adverse outcomes such as maternal, neonatal deaths, prematurity, stillbirth, miscarriages, and gestational diabetes. And throughout the project, we were aiming to engage the hospital and the Ministry of Health team to develop this risk factor model and therefore a dashboard to inform service delivery within the hospital. So among our achievement was really high level engagement with those teams. And this particularly helped to guide the dashboard development. It also helped us to identify what are the key variables, what are the key risk factors that would include in our model. And throughout the interactions, we were able to realize excitement and acceptability among the service providers and particularly hospital level teams within the hospital. And this kind of initiated a use case and ongoing commitment by the hospital team to be able to use this dashboard once we had developed. So the dashboard was developed, as you can see on the screen, and this is now in use at the hospital. We also were able to present the work from this study or project at the Global Health Network Conference in South Africa. And also we have a manuscript still in development and hopefully to be submitted soon for publication. In terms of learnings, we thought that throughout the project we're using, like Neil introduced earlier, using the trusted research environment, which we found quite secure, and this improved our internal collaboration and sharing of information within the team. The data curation, which is quite an extensive exercise, we noted that yes, while this is important and an engaging process, we learned that it's important for routine data to be rather reviewed and think of the quality of this routine data, and that would rather save on the time that you spend on curating or cleaning and trying to improve the quality of this data at the time of use. We also noted that engaging stakeholders was very, very important because this improved ownership of the process and therefore would initiate continued use of whatever we developed out of the project. Now the dashboard matches was our primary goal was to develop it for use within the hospital this has created excitement by other stakeholders providing services within the hospital. And therefore, we hope that that kind of excitement will enable sustained use of this dashboard going forward. As a key message going forward is we think that as routine data becomes a single huge opportunity for data science to model and predict health trends and emerging gaps, we hope that we can, one, engage the partners in improving the quality of data that is collected routinely, and also be able to develop international or adapt international classification or coding databases or dictionaries into this database to ease the process of analysis and making use of this data. That's all I need to share for now. Thank you very much, Neil, and everyone for listening to me. Thank you. I hope Lauren has anything to add.
No, you did. Perfect job, Joseph.
Wonderful. Thank you, Joseph. Perfect. Excellent. Right. We move apace to Dr. Julian Oliveira for routine assessment of infections, prevention and control of SARS-CoV-2 on unequal populations. Julian, are you there?
Hello. Again, thank you for inviting me to participate in this event. And it's really a pleasure to be sharing some of our output with everybody here. So I'm Juliana Oliveira, mathematician and researcher associated to CDAX from Fiocruz. And in this project, our goal was to develop a data visualization and analytics platform to evaluate the impact of SARS-CoV-2 transmission in Brazil, taking into account the social and economic inequalities of the country. So to achieve this goal, we managed to create the platform for analytical models in epidemiology, which we shortly call PAMEP. And also, perhaps you have heard this on the 40 about PAMEP a little bit. And in this platform, we show how we built a data lake containing data on health, non-pharmaceutical interventions, immunization status, human mobility, and socioeconomic determinants, which describe the whole profile, can describe the whole profile of the pandemic situation in Brazil. So the data are further aggregated and available for studies on each of the 5,570 Brazilian cities. And we believe this is a very good resource we managed to gather together, especially now that we are having again a crisis on data provision in Brazil about the pandemic. To stimulate data reuse, we provided video tutorials, documentations, a user-friendly visualization of the metadata with the translations like in Portuguese and also in English, and codes on our GitHub repository. We have also won recognition award for this work and highlighting, describing how all the researchers can participate and produce new insights for the data that we made available. We also, you can also see, it's shown on this platform that we perform data analysis and modeling, which were essential to obtain data insights, build descriptive data visualization, as you can see like a print on this presentation, understand the dynamics of the disease in the country, estimate the effect of inequities, and produce material for public engagement. In addition, we have also created a routine to include modeling outputs on the dashboard and a panel for users to explore mathematical models. So we really wanted to go beyond and spread the impact of mathematical and statistical modeling. So nowadays we have this panel where user can upload the time series, for instance, and then see how is the effect when they manipulate some parameters on the data they have. So it's kind of a manual fitting mathematical models to the local data. We were thinking about that because during our scientific dissemination, several local health managers from the secretary and even journalists, they were asking to us how we build the models, how we estimated the reproductive number, and how we get like some model insights. And some of them also asked if we can provide codes for them. And then we imagined that having this simulation panel would be also of interest for the broad public. We are very happy with the progress we have made in public engagement with both the media and the stakeholders. We were really surprised on how we managed to really get the population involved. And I think this knowledge we gained during this period will be really important for next health issues in future. And overall, I believe that we exceed our expectations. So in addition for all these platform, we had the publications, some of them they were already accepted, some of them we are concluding and we are going to submit now. And we build capacities that can be adapted to other public health contexts. We strengthen modeling and we prepare in particular for the next pandemic. So that's the overall presentation of our project, and thank you all, and thank you in particular to all the support that it was possible for us and made available for us to do this work.
Wonderful, thank you, Julianne. Right, we go now to Dr. Maria Yuri Ichihara on evaluating effects of social inequalities on the COVID-19 pandemic in a low and middle income country, that country being Brazil. Maria, are you there? Maria? In which case, let me pause on Maria for a second.
No, it's the slide is not here.
Ah, okay.
Okay.
Is that the one you wanted?
Okay, it's okay.
Perfect. Take it
So
away.
I'm Maria Yuri. I'm from the Center for Integration of Data and Knowledge for Health, Oswaldo Cruz Foundation in Bahia, Brazil. It's a pleasure to share our experience on using linked administrative data to build a social disparity index for COVID-19 to evaluate the effects of inequalities on pandemic in Brazil. And considering that the most vulnerable people were severely affected by the pandemic in Brazil, one of the most unequal countries in the world. And when we say most vulnerable people, we are talking about Black population, poor people, people ages 60 and over, people living in slums, or with a high household density without sanity. In this context, pandemic contributed to deepen the existing inequalities. So our study aimed to evaluate social inequalities effects on the COVID-19 pandemic in Brazil. How did you do that? Based on socioeconomic, socio-demographic, and barriers of access to health services indicators, extracted from 7 linked administrative data available in public domain, such as Census 2010 microdata, Brazilian Deprivation Index database, National Register of Health Establishment. We created the Social Disparity Index on the COVID-19 in more than 5,500 municipalities for the 4 moments on the pandemic, before the pandemic, first, second, and the third wave of the pandemic, to understand the role of inequalities on health in the COVID-19 pandemic to target social and health policies. The IGS COVID-19 is available in an interactive public dashboard that may help policymakers, health managers, communities, groups, researchers, practitioners, journalists to analyze the social disparities by the geographic level. Brazil as a whole, macro region, state, capitals, healthy macro-regions, healthy regions, municipalities, and even to compare the evolution of the situation of social inequality in health in the 4 moments of the pandemic, and compare these indexes with the epidemiological patterns of pandemic according to the groups of municipalities, using an innovative method called the dynamic time warping barycenter averaging. And to build these patterns, we use the daily notification of cases and deaths from the state health departments and the administrative data available in public domain. All the metadata is available on Dataverse, and the data used in the study is available in the fair space of the workbench. In the dashboard, you can see the situation of social inequalities for COVID-19 in the pre-pandemic period, and you can see that over 50% of the municipalities of Brazil had a high and very high inequality on health, and most of them were from the North and Northeast region, in contrast of the 20% of low and very low inequality concentrated in the Southeast and the South region of Brazil. And this situation remained during all the pandemic of COVID-19. We could see even that the worst STI COVID-19 had a clear relationship with the most intensity of the epidemiological patterns according to the groups of municipality. And the potentialities of this index are the ability to capture social health inequalities of pre-pandemic COVID-19 and its evolution during all the pandemic. It allows to highlight historical situation of inequities in health by incorporating an indicator of race color and the measure of difficulty in accessing health resources. And with this, we expanded the discussion implementation of the organization of healthcare in the unified health system, and by focusing on the principle of regionalization. It has easy reproducibility by using the scoring method, and it allows incorporation of new indicators and new domains upon availability of information. Would you like to highlight your experience of public engagement? And we have an amazing experience of dialogue with different groups from 13 states of Brazil during this project, and you produced a documentary named Beyond the Social Distance, Dialogues to Understand the Social Inequalities in the COVID-19 Pandemic. We expect to submit 2 articles today about the engagement, the public engagement on science, and about the COVID-19 time series clustering. And we are finalizing 2 other papers about the index COVID-19 and the data visualization as a strategic educational action to disseminate useful information in pandemic. Also, we present our results in the International Population Data Linkage Network in Scotland and in the National Congress of Collective Health in Brazil. Finally, I would like to talk about the lessons learned during carrying this project. And I think we could learn how to monitor the COVID-19 pandemic according to social inequalities in health, with the possibility of expansion to other public health emergencies, how to provide useful information to vulnerable groups, stakeholders in society, how to develop research involvement engagement with a multidisciplinary research team focusing in social groups and stakeholders, and to promote open science by disseminating metadata from COVID-19 databases used in the project. We think that this impact of our study can contribute to guide public policies, offer epidemiological parameters focusing resources on public health policies, and reinforce the principle of regionalization of our health system. And finally, I would like to thank all the support of the team of the ICODA and the Bill Melinda Gates Foundation. Thank you.
Wonderful. Thank you, Maria Yuri, and good luck with the submission of the publications today. Okay, fantastic. All right, so we go next in the relay race to Dr. Fernando Boza on effectiveness of COVID-19 vaccination in Brazil using mobile data. So Fernando, over to you. I do have 3 other charts as well as this one, so do ask me when you want me to move forward.
Okay, thank you for the opportunity. It's really a great time for us and for my team. First, I would like to thank my team, and this is a multi-institutional group that worked to respond some questions that goes from the vaccination campaign in Brazil, especially vaccine inequality, vaccine effectiveness, vaccine impact, but also a view around the resilience of health system and also community-based studies and interventions that we developed during this period of one and a half year of this project. We use different methods of data science, from data visualization, causal inference, predictive model, and machine learning approach. The data source that we use come from the Brazilian health, universal health system, from the surveillance system, but also very granular data coming from hospitals and also cohort studies that we developed during this intervention in a poor community in Rio. Then we, during the project, we look at different aspects of the vaccination rollout in Brazil, including inequality, but also impact of vaccination using more than 200 million vaccine doses. For other side, we also look at also antibody response and other aspects of epidemiological control. From the health system resilience perspective, we generate a framework for resilience in ICU, and also we analyze the relationship between resilience and efficiency of health system. But one major achievement was also to develop an intervention in a large community in Rio de Janeiro with more than 140,000 people, where we first we acted using data to improve the response of COVID-19 in that community, but also we evolved to a massive vaccination campaign where we vaccinate more than 36,000 people. In 4 days, we achieved almost 100% of this community vaccinated. This generate important paper around the vaccine effectiveness in this community, but especially generate a lot of learning, how to mobilize, how to communicate, and how to engage community around vaccinations. As outcomes, we produce a website, 3 dashboards with different analytical tools. We worked in 21 manuscripts. We have 4 manuscripts accepted, 9 submitted, and 8 in final draft. Also, we produce 2 documentaries that are available in YouTube, USF repository, code scripts in GitHub, and datasets in a reader platform. As a major challenge and perspectives of this project, we can tell that improving governance, privacy, and sharing guidelines as a major achievement from our group that comes from this initiative. Of course, the big data challenge of to work this large amount of data, but also was a major point, how to democratize, how to use new technologies to provide us access to healthcare in poor communities, and especially how develop people-centered community-based research, integrating data in primary healthcare. Thank you so much.
Thank you, Fernando. Wonderful. Right, let me gallop through those, and we will pass the baton to Professor Andrew Poole on addressing critical COVID-19 questions through research using linked population data. So Andrew, are you there? Hello, Andrew? Possibly.
The slide is not here.
Okay, I will go to our next presenter. I think this is Dr. Stephanie Joseph on behalf of Jean-Claude Mugunga on the impact of COVID-19 on chronic care patients, healthcare utilization and health outcomes in Haiti, Malawi, Mexico, and Rwanda. So Stephanie, are you there?
Yes, hi everyone.
Brilliant.
Thank you
Thanks,
so
Stephanie.
much. Hi everyone, and thank you for this opportunity. I'm Stephanie Joseph, a research analyst at Partners in Health, and I'll be presenting on behalf of Dr. Jean-Claude Mugunga. And I just wanted to state that this project was a collaborative effort through the Global Research Core, which includes Partners in Health, Harvard Medical School, and Brigham and Women's Hospital. So just some background information. The COVID-19 pandemic had negative impacts on clinical outcomes and chronic care patients' access to care. However, few studies explored this quantitatively within low-income settings. So this gap prevents us from prioritizing which clinical populations would benefit the most from either additional support and from learning from clinical programs that have successfully mitigated the impacts of the COVID-19 pandemic. So our goal was to determine how the COVID-19 pandemic has impacted healthcare provisions and utilization for patients with chronic care conditions and health outcomes of these patients in these 4 listed countries. So this project involved a retrospective cohort of diabetes, HIV, and hypertensive patients from PIH-supported facilities in Malawi, Haiti, Rwanda, and Mexico. And we used electronic medical records to compare 6 and 12-month loss to follow-up, death, and composite outcomes of death or loss to follow-up among patients alive and in care pre-COVID, which we defined as March 1st, 2019, to those alive and in care post-COVID, which we defined as March 1st, 2020. Appointments attended, appointments scheduled or observed, and the ratio of attended to scheduled appointments among these patients were also compared. I also want to take this time to acknowledge that the site-specific and cross-site data owners who did their due diligence to make sure this data was available to us. Next slide, please. Thank you. I also just want to highlight some key actions. So we were able to create and share metadata for a harmonized, pooled, multi-country database using aggregated data of patients with chronic conditions, so HIV, cardiovascular, and diabetes. And so this included a lot of data processing, EMR data extraction, data user agreements between the sites, cleaning and finalization of clinical outcomes, assessing monthly missed appointments, as well as a syndromic surveillance data set. We also were able to quantify disruptions in care and outcomes of patients during the COVID-19 pandemic. And the timeframes are just listed there from March 2020 to February 21, compared to before, including March 2016, all the way to February 2020. With the help of Veridia, we were also able to develop a tool to do pooled analysis, forest plots, and other visualizations of our results. This helped us to facilitate communication and interpretation of these analyses by stakeholders in these 4 countries. And we were also able to disseminate clinical outcome results of predictive models to site leads and research teams in participating countries and identifying some next steps. Lastly, we submitted progress reports, financial invoices, and prepared a final report. And we also were able to start the work on a manuscript. Next slide, please. Thank you. So just to conclude, I would like to state some of our lessons learned, such as navigating complex EMR data sets in varying formats. This included a staggering analysis plan to focus first on HIV patients and then on cardiovascular and diabetes patients. So we ensured that we leverage these skills and lessons learned while preparing the initial sets of EMR records. Another major impact of this project beyond this analysis work is that it made our organization realize the need for further investigation into these data systems, which includes organizing and expanding the EMR data use, and also creating an easier system in order to pull this data in a curated database that is already ready to analyze. And lastly, we are embarking on developing some strong, flexible data governance structures that allow trusted collaborators as well as access to de-identified individual data level while upholding both the care and fair data principles. Thank you.
Wonderful. Thank you very much, Stephanie. Right, we are going to go back now. I think we have Andrew. So Professor Andrew Bull, would you like to join us and talk about addressing critical COVID-19 questions through research using a linked population data? Are you there?
Great, thanks. Can you hear me this time?
Ah, brilliant. I can. Fantastic.
Perfect. Okay, apologies for earlier. So first, just to echo what others have said, to thank the funders and the initiative. We're very privileged to be part of this initiative and have really benefited from it. I'm a public health physician working for the Provincial Health Department in one of the 9 provinces of South Africa in the Western Cape. And essentially what we have been doing is assembling all of our routine health data in a consolidated data environment. And the ICODA resources really contributed to the data engineering effort to maintain a number of linked data sets which we could de-identify and make available for analysis. We started out with quite a few varied objectives, all kind of framed by the emerging variants that were coming to the fore at the time that the project started. But in fact, most of what we've produced in terms of publications at this point has been on variant severity, and some of the other epidemiological analyses have taken a little bit longer to mature. So it was a collective effort done within government by the public health component of government, which includes the data center and the epidemiological team, a small team. And I just want to acknowledge Professor Marianne Davies, who led that team and has been instrumental in a number of the outputs. You'll kind of see from the graph on the bottom left just how the epidemic unfolded. This is one of our poorer areas, and quite a fulminant epidemic initially, and then each successive wave being less and less, showing kind of saturation of the population with infection. And you can see Omicron emerging with the breakthrough infections in orange, demonstrating the immune escape. Which led to quite a few challenges in terms of epidemiological analysis. If we can go to the next slide. So if you look on the left, you'll see the kind of data sources that we routinely integrate. And when we started, we initially integrated a data set on cases, all diagnosed cases, all admissions. And this was our daily driver for our service response, but it was also the basis of looking at comorbidities and associations with outcomes. And just prior to ICODA starting, one of our first analyses had been to look at the severity or the association between HIV and severe outcomes, and it was facilitated by the first 2 data sets. And this became the daily driver for kind of looking at variant severity, although the data set is, there's a selection bias for people who are more likely to test, and that bias was considered to be consistent across waves, and so we could look at variant severity. And a key contributor, and what really showed the value of having laboratory data in the same database as patient data, was the cycle threshold data by target. And one of our virologists was able to identify there was a target delay in the Delta variant that allowed us to distinguish Delta from Beta, but also Omicron from Delta when that target delay preceded, which allowed us to look contemporaneously at patients with the same health service conditions and also with the same probability of prior infection. And that was a great triangulation with the looking across waves longitudinally. But because of that selection bias, we also created a population data set of everybody who was active in the services. And then we looked at severe outcomes where we thought that ascertainment would be complete. And it was a summation of probability of being infected as well as probability of progression to severe disease. So we couldn't unravel those, but we could look within communities where we thought the probability of infection was similar. And that was really now enabled us to look at associations with outcomes without the bias of ascertainment. But then as the variants progressed, the probability of having been infected in the past was higher and higher, and we were only ascertaining about 1 in 10 from our testing. And so we were able to do a serology study on convenience samples of people who were coming to the services for routine testing for HIV and diabetes, pregnancy screening, and even just children coming for acute care. And within that serology data set, linking through to the vaccine data and the clinical data, we were able to then look with knowledge of prior infection, because we could look for anti-N and anti-S antibodies. We could look at the relative contribution of prior infection and vaccination. And the biggest challenge there was, by the time we had high levels of vaccination, it was the Omicron variant where we had those breakthrough infections I just mentioned. And in our data set, maybe different from some richer countries, we didn't have very good data on the clinical events associated with admission. So we didn't know whether people were admitted because of COVID or they were incidentally infected and admitted for other reasons. And that has compromised some of our analyses and some of our vaccine effectiveness analyses. And then the main lesson really was that having a data center team, a group of data scientists who work with routine individuated health data on a daily basis was really critical to being able to pivot very quickly to being able to answer new questions in the context of a pandemic. And building the data science capacity within routine health services for us is a key priority going forward in terms of readiness. Thank you very much.
Brilliant. Thank you, Andrew. Excellent. Right. And 12 of 12. It's not Jean-Claude. Hang on. What have I done here? Oh, we went back for Andrew. So I'd like to invite Dr. Luis Felipe Reyes Velasco to talk about data descriptor reference coding and characterization of the systemic complications of critical care patients included in the ISARIC COVID-19 dataset, more fondly known as DP-ISARIC. Luis, are you there, and can you bring us home?
Hi, yeah, after such a long title, I will try to be short in the presentation. So yeah, first of all, I would like to thank all the sponsors and the funders, because this opportunity has been an amazing opportunity to work with different people around the world and to bring something useful for the scientific community. So first, the problem that we have in mind is that, so as many of you may be aware, the ISARIC dataset is one of the largest multinational datasets collected during the pandemic. Currently, this dataset is composed by by around 1 million individual records, and all these records are coming from more than 50 countries around the world. So it's such a rich dataset. Mainly at the beginning of the pandemic, mainly patients were enrolled in the United Kingdom. But as you can see in this figure, then at the end of the pandemic, we have people all coming around the world. However, the challenge, as you can imagine, is how to integrate all this data. So ISARIC has come with a very clever idea to try to merge data sets, not only those that have been collected through the ISARIC platform, which is easy to collect and easy to handle, However, they accept different kind of formats that people can submit to the data to the ISARIC. The problem with that is that all these formats are not comparable, and that we have different data points, different variables that have been collected in different studies. So the way that they deal with that was to unify all these different data sets in one, using a unified structure. However, this unified structure is highly complex. It's highly complex because it divides the data in 16 different tables. And those different tables is what we call a relational kind of data set. So those 16 tables are connected each other. However, is not a stray away, easy to use data set. So in ISARIC, people can access the data through a regular process. However, once they receive these 16 huge tables with all these records, it's almost impossible to navigate the data set. So with this grant, what we did was to develop a unified and data code that is able to generate how to you extract data from each individual patient registered in these 16 tables. And then at the end, you will create a data set that is easy to handle and friendly for you to make the statistical analysis. So we were able to create a code to do that. And on top of that, we created a data descriptor manuscript that you can see in the slides, where we describe all the complex structure of the data set and how people can navigate this data. And on top of that, we create the code. We put the code that we create, we put it in a GitHub so people can easily download the code, can easily enrich the code or make it better. And it's an active community that is working towards improving the data set and towards improving the way that people are using the data. So with that, if you can go to the next website, next web, there we go. Here you can see all the patients that we have included here. In the previous slide, I showed you the manuscript that we create. And with that manuscript and the code that we develop, we have more than 30 citations already. We have a brilliant community working towards improving the usage of these data sets. And we have analysis coming over all these countries in the map. If you go to the next one, please. And then, as I explained before, ISARIC is composed with all these data sources, but the code that we developed was using different sources. So we use Python, R, SQL, and then with that code, people can easily go to a more friendly and easy to understand kind of a statistical approach using the R or Stata that is widely used. And with that, I think that it's been an amazing opportunity to create a way to use the data, because it's not only important to gather the data, to collect it and put it in a website. It's also important to create a strategy that people can use it. And you don't need to be an expert data scientist to be able to use this kind of data. With this kind of approach, we teach people how to use it, and we ensure that we have a greater impact with the data that has been collected. Thank you so much.
Wonderful, thank you, Luis. Absolutely fantastic. And I think, well, what a wonderful set of projects, and thank you to everybody for bearing with us and trying to squeeze what's been an amazing few years of work into just a few minutes. But that's been an incredible set of results from all of you, just outstanding. I'd like to pass the baton now to Dr. Steve Kern, who has been a huge proponent of the initiative all along, starting out as our funder and now interim CEO at Global Health Labs and special project lead at Gates Ventures. So Steve, a few words from yourself, follow that.
Great, thank you very much, Neil. And it's really an honor actually to follow my co-organizers and collaborators in this overall effort that you heard from at the start of the hour or 2 hours ago. And then also just to hear the great updates from the 12 projects, really impressive in terms of the impact that was generated from this effort. And we undertook this project as part of what was called the COVID-19 Therapeutic Accelerator. And that was a consortium of funders working together to accelerate the impact of developments to address the challenges in the pandemic. This specific project with ICODA was led by Minderoo Foundation from Australia, and you heard from Kim earlier at the beginning, and then the Bill and Melinda Gates Foundation in the United States. And the intention of the activity, as our good colleague and leader of our advisory board, Agnes Banagawaho, said at the start, was specifically to accelerate sharing. And I want to highlight sharing of data as a catalytic input, but also sharing of insights as a catalytic output, because those two things are desperately needed if we're going to actually have a response to a global outbreak as we had with COVID-19 that's going to be impactful. Similar to what Kim had mentioned from Minderoo, sharing data from research investments is a key motivation at the Gates Foundation, particularly sharing that enables researchers who actually collected the data to lead the analysis and get credit for the insights from that result. I think what we saw just now were, the 10 ICODA Grand Challenge projects and the 2 driver projects as well, all together making 12 driver projects, contributed to the wider community of data science grand challenges that enable secondary data reuse to answer complex research questions and inform global health interventions. This is a continual effort that the Gates Foundation is promoting through the Grand Challenges mechanism. And through that, we've now built a community of over 53 research groups, which would actually then equate to more than 100 researchers who are working in a collaborative network, loosely defined, around grand challenges that enables them to share tools, insights, and opportunities for learning. The driver projects really focused on rapid and innovative outputs, not just publications. The publications are critical and they're important and they're really great to do now as we wind down and start to learn from those analyses. But importantly, we want them to support interventions, decision-making, and community efforts across different geographies in the middle of a pandemic. And I think, we can discuss some of the challenges that we had in trying to achieve that objective. It's a tall objective and difficult to do. I think the driver projects really also addressed priorities defined by WHO. They had different types of data, as you heard, and really some innovative approaches in how to analyze and address the challenges posed that those data could address. And you're really showing some amazing and substantial multidisciplinary global collaborations. That was actually just witnessed by looking at the breadth of the number of researchers in different countries who came together to actually work in a collaborative manner to address these problems. We also identified pain points of convening experts to work towards collaborative solutions. That's really key because those learnings are really important for us to be able to know how to do better at the next time that we have a global challenge that we have to face as a scientific community. And this global community of practice that we've developed, we're looking forward to continue the impact and partnership with the broader data science community through the Grand Challenge mechanism that the Gates Foundation and a community of funders all contribute to. So, I'll finish by saying the work we just heard summarized is tremendously laudable. It's really great to see the outputs and the impact and the assessments that have been done. But we should not stop here with just publications and instead, continue to think about how do our learnings, which largely trailed after the waves of COVID-19 pandemic, how can we build those so that going forward, these insights can help us lead a response for a future infectious disease outbreak challenge with preparedness and resilience. You heard Andrew Boole actually specifically talk about that in the Western Cape as an example. And I'm sure that many of you, your programs as well, are thinking along these lines. Let's not disperse as a community, but use this as a catalyst to join as a community as we try to think about proactive solutions that we can apply at the beginning of the pandemic instead of racing afterwards at the end. So I want to thank all of the researchers for your tremendous work during this project. I want to thank my collaborators that in funding, particularly our collaborators from the Minderoo Foundation. The ICODA team did a great job working with Iridia as a provider of technical workspace. A number of our data science teams, one that Naveen Zarifa was key in instigating to help pull together statistical analysis consultation capabilities, and also to have help with data curating, some of the really tough lifts that happen when we're trying to do these problems. And I want to thank all of you for joining us today and learning about these great responses. And I'll turn it back over to Neil for, I believe, question and answer next.
Wonderful. Thank you, Steve. Perfect segue. So Anne and team, do we have any questions for either ourselves or the research teams that we need to cover?
Yes, indeed, we do, Neil. Some really good questions have come up. If I could just open the discussion with a question from Hilary Henneho, a key partner at RDA, who, like the rest of us, I think, wanted to thank the PIs for the excellent presentations and wonderful work that's been conducted. Hilary's particularly curious about some of the data access aspects, particularly where the summary requires access via data owner and permissions to be given. In the context of fair data, she questions, what does this really mean? What are the restrictions, and what does accessing these particular data sets entail? And just to start us off, I'd like to ask Dr. Catherine Arsenault if she might want to give her perspectives on this, particularly in the context of working across multiple countries and data sets.
Thank you, Anne. I'm happy to share some thoughts on that question. I think, so in our context, we use HMIS, DHIS2 data from 10 different countries. I think in a lot of these countries, these data are owned by the governments, the ministries of health generally. I think they were happy to share the data for the purpose of this study, and we collaborated with academics locally, so the data were available for research purposes. And I think, so in terms of accessing the data, I think the difference between the FAIR principle is not that the data are open, completely open and accessible by anyone, but rather that there is some transparency in how the data were obtained and generated. So in terms of what this means for our data, we have shared the metadata, excuse me, on the HDR platform. So what this means is that the data are findable. And we also are making sure that we are still able to provide the proper channels for others who would want to request access to these data sets to the ministries who want to know what the data will be used for and for what purposes and by who. So I think those are my thoughts.
Thank you very much, Catherine. Neil, is there anything that you would like to follow up on the comment?
I think Catherine's answer was wonderful. I would note that some of the projects have data which is openly accessible. There's a real variety of data types and data accessibility across the projects. And to Catherine's point, findable, accessible, interoperable, and reusable. The accessible word has to be augmented with trustworthy access processes as well. And part of this initiative was making some of the more sensitive data accessible inside trusted research environments as part of safe projects, safe settings with accredited researchers, etc., which Anne talked about earlier. So freely accessible is not necessarily trustworthy depending on the data sensitivity, but it's a great question.
It is indeed. Thank you. Well, we have another really interesting question that's come from Julianne to all her fellow researchers. One of the key things of the ICODA projects has been the rapidity with which excellent sort of insights have come through. And Julianne's asking, throwing the question open to all her fellow researchers, what lessons would you like to share in being able to provide and pull together good quality data and still produce a large amount of publications and other outputs in a very short period of time?
Sorry, Anne, who was that to?
It's an open question from Julianne to her fellow research leads.
Very good, I'll keep quiet.
Anybody like to take up the baton?
Sure, I'll handle that. It's Naveen. At least I'll give my 2 cents. It really helps to have an established community and or an established way of working. So pulling together in the way that I described the COVID-19 summary level data from publicly available sources was enabled because the Certara team had done this in about half a dozen other disease states. So they had a well-honed machine. I would say that the groups that are now up and going, if the relationships can remain active by doing important work, then the next time we have a health crisis, we'll be in an even better position from a data and analytics perspective.
Thank you, Naveen. Very, very key points there. Would any of the other research leads like to add any comments? So I'll move us on. We also have another really key question from Julia. Beyond the valuable insights generated by the teams that delivered the driver projects, what do particularly the researchers beyond that, the core team, feel are the enduring legacy of ICODA? And beyond that, what are the priorities to ensure that this legacy is realised?
And so shall I chime in on a couple of those?
Indeed.
So certainly, Julia, great question. And the enduring legacy is yes, the research papers, but to Steve's point, far more importantly as well, is that the metadata accessible and available such that others can request access to the data. The openly provided governance processes, both the ICODA ones and the genericized ones, I hope will be really useful to research teams around the world. The partnerships that we've forged, I really hope are long-lived. I think we've had some fantastic partnerships, and we'll talk just briefly about some of them in the acknowledgements. But those partners stand ready to help any of the research projects around the world with their working. And I think that's going to be a really valuable one going forward, as is the co-working across these cohorts of researchers. So the research teams have presented their individual work, but the collaboration has already started in the background, in the context of those research collaborations, but also in the context of HDR Global and the Global Health Network, which we'll talk about as next steps, just to close this session out. So I think lots of things which I hope will leave a lasting legacy from the initiative.
Neil, this is Marty. I'd like to add perhaps a rejoinder to that. And that is from the sponsors, the sponsorial collaborations that have really brought us to where we are, instigated and nurtured. There have been relationships, I bet, that have been strengthened and other ones de novo created among sponsors. And I would hope that they form that kind of an alliance, not only in continued support of the work of ICODA, but in preparation for the next major opportunity. Thanks.
Thanks, Marty. Great point. And do we have any others?
I think we have completed the key questions that came up. So thank you very much indeed.
Fantastic. Right. Well, let's jump straight into
And
acknowledgements.
Neil, I'll just make one comment actually at the end, and following a lot of the points that were just made. You know, there is a real interest in by the funders to create the catalysis for these kinds of collaborative interactions. They don't always specifically ask for that in grant fundings, but one of the things I would really encourage the community is to continue to demand that from us as funders, right? Continue to demand the opportunity to work collaboratively, to put that into the costs of your grants, that both in costs in terms of, you know, financial costs, but also time costs, because these are more complicated to do. But hold us accountable to being able to want to motivate that, because I think we want to do that. We need to be reminded sometimes of that as funders. And I think the more that you as a research community come to us with really collaborative, creative projects, the more you'll continue to enforce or drive our willingness to head down that path. So, you know, it's a two-handed game in some ways, not just for the funders to lead, but actually for the research community as well to pull. And so, you know, please continue to do that, especially if you found this exercise to be reinforcing. You know, I would highlight that in your future applications, either to the Gates Foundation or any other funder. Thanks.
Thanks, Steve. Great point. Okay, a couple of bits to close us out here. We're quite tight on time. Acknowledgements. So firstly, one more time, a huge thank you to ICODA's advisory bodies and executive leadership team, the Scientific and Strategic Advisory Council, Ethics Advisory Council, executive leadership team, and Stats Expert Group have stuck with us for the last 2.5 years, provided their time pro bono and kept us on track as an initiative. So thank you. Thank you to the Alliance partners as well. We've had a really broad spectrum of partners right across the Alliance, and you can see a selection of them there. They've really kept us on track, and anytime we've needed anything, they've been a great community to reach out to. Our technical delivery partners, we've mentioned some of them as we've gone through. So Iridia Informatics provided our trusted research environment. Cytel provided meta-analysis tooling and statistics expertise. MMS Holdings provided data curation support to the projects. BA Consulting provided technical development as we took HDR's Innovation Gateway and rebadged it and branded it the ICODA Gateway for fair metadata sharing. Sale Databank provided us with data storage, governance expertise, and federated analysis. Satara, Naveen mentioned, provided us with a fantastic codex tool set. Preva Group have kept us continually on the straight and narrow from governance processes perspective and making sure that we do things in the right fashion. And Microsoft AI for Health have supported the initiative and providing Azure Cloud Platform support all the way through. Our PIs, you've heard from the majority of them today, and their research teams, because of course that they are presenting, but there are research teams behind them. There were 135 researchers involved with ICODA, and to the public, patients and communities that they have worked with along the way. So a huge thank you to everybody on that front. And last but most certainly not least, a huge thank you to our funders, the Bill and Melinda Gates Foundation, the Minderoo Foundation, and Microsoft AI for Health, who've been with us every step of the way. They've really been fantastically engaged funders and have provided their own insights as we've gone along this journey. Last but certainly not least, a huge thank you to the ICODA team themselves. It's been an absolute privilege and pleasure to work with each and every one of you throughout the initiative. Today, and it has evolved, we have had a number of different members of the team, but today we have Sally Boylan, who's our project whiz. We have Matt Retford, who's our technical whiz. We have Edel McNamara, who keeps us straight on governance, and Sarah Fulliger, who has been our comms guru throughout the ICODA initiative, and my wonderful co-lead, Anne Wozencraft, who you can see on screen. It's been my personal pleasure to work with each and every one of you and previous members of the ICODA team for the last 2 and a bit years. Without you, we couldn't have been successful. I'm going to pass the baton just for a moment to Andrew, who I think has joined us in the background, and then Anne will just bring us home with a couple of bits of what next. So Andrew, do you want to call anything out? Andrew.
Afternoon, team, and apologies for missing this afternoon. I was at a funeral of a very close friend and very good doctor, so it was an important day. But I understand you've had a fantastic 2 hours, and just to say a huge thank you to everyone, to echo Neil. You know, to me, this wasn't a data project, a technical project, or even a science project. It was about could we build a global social infrastructure and a global team to do something really special? And I think the evidence is that we have come together quite remarkably across research, service delivery, policy, funders, industry to deliver a global, and it's Steve's phrase, a mesh network, which is really enabling of team science, so that people at the front line around the world don't spend 80% of their time looking for data or finding data. Can we really make data science really frictionless and enabling on a equitable and global basis? And I think we've scratched the surface of some of those issues, and it has required real teamwork. Great to see a few folk on the call. Folk like Agnes and Marty, who were tremendous. Frank Rockhold, who is absolutely outstanding on the advisory board. Nicola Perrin, who did a lot of the heavy lifting on the governance. And of course, Steve and Kim as funders. So I think this has been a great program. And I'll finish with a quote, because I think the social infrastructure of this project is probably the most important thing. To echo Steve. So my quote is, find a group of people who challenge and inspire you, spend a lot of time with them, and it will change your life. So let's not give up. Let's keep going as a team. I'll even forgive Fernando, because I was giving a talk in Brazil the other day, and I recalled that Scotland have played Brazil 10 times at football, and Scotland have never won. But despite this, you're the most wonderful collaborators. So anyway, thanks, Neil. And we're not going to give up. And we're in the foothills of where we are going to go. So I'll stop there.
Perfect. Thank you, Andrew. That is the perfect transition to Anne, who's going to bring us home with what next. So Anne, over to you.
Thank you very much. And just to add my thanks to everybody, it's been an absolute privilege to work with you all. So exciting developments. As many of you know, we have now established a new wider HDR global program, which will build very much on the legacy of ICODA. And the initiative will not just focus on COVID-19, but on a wider group of health challenges. And the focus of HDR Global Programme will be to enable trustworthy data access, reuse and analysis in regions, communities and areas of global health challenge where evidence to tackle threats to public health is lacking. And already a number of very key developments have been going on in that programme, and there will be a link at the end so you can see about the exciting activities that are happening in HDR Global. Absolutely key to that is the partnership that we've established with our 3 regional partners in Asia, in Africa and in Latin America, and with the Global Health Network. And we very much look forward to working with you all in the future. And I'd like to hand back to Marty just to close and to thank him once again for his wonderful sharing this afternoon.
And thank you. It gives me therefore an opportunity, I'm really pleased to say, that since Andrew, you've been able to rejoin us, to give a standing salute to yourself, sir. You provide not only the perspiration, the leadership and the leadership by example, but an inspiration that truly has not just brought us to the fold, but knitted us into your clan. And what a great clan it is. We should have a special tartan that we all wear next time in respect for you, Andrew. It's been an absolute privilege to serve with Agnes Benawahu, who I have come to love, respect, of course, and yes, a little bit fear. When you say you're going to do something with Agnes in the room, you better deliver and deliver well and on time. I love it because that's what this is all about. It's all about not the numbers, but recognizing that each of these numbers that we describe as data, they are all patients with their tears wiped away. These 2 hours, these 12 splendid presentations, these facets on the ICODA diamond that have been carved, created by these 12 marvelous driver projects, hold hallow the memory of those who have died of this disease or its complications, and the awfulness that our world has experienced as a consequence of the pandemic. I salute each and every one of you for the dedication and devotion that you are putting to, now and in the future, these so-called numbers, because they are very special patients. Bless you. Andrew, and is Agnes still here?
Yes, I'm there and I'm following.
Then Agnes, please give us your benediction. I sign off with gratitude.
You know, I think that this is quite an example of what the future should be. That what we do, we share it as soon as we can for the benefit of the patient, whatever place they are. So I'm so optimistic because we have been all together stronger after this pandemic, and it shows us that we are on the right path. So thank you. It's a privilege to be with all of you.